I'll try to avoid the overlap, and I kept the presentation very briefly, focusing on the practical points, and then we will focus on the common things which cause problems in the pregnancy period. So the topics given to me were gallbladder disorders in pregnancy and acute pancreatitis complicating pregnancy, and incidental splenomegaly, organomegaly, which can cause problems in the third trimester. So gallstones, as Naveen was telling, are common in pregnancy due to hormonal and physiological changes, and increasing adolescent and childhood obesity, we will be seeing more number of gallstones, and incidence is around 3 to 12% based on the region and the dietetic habits, and also the obesity factor should be taken into consideration. Fortunately, most of them are asymptomatic, but complications can arise, and gallstones will come in various shapes and sizes and numbers, but most of the time, these young people may have just cholesterol stones. Why is it relevant in pregnancy? Because you see them very frequently in routine scans, and progesterone increases biliary stasis, and estrogen increases cholesterol secretion, and there is a hypomobility of the gallbladder. Fortunately, because of this, there may not be dislodgement of the stones. That's why you see less complications during the pregnancy, and infections can come in a patient with gallstones. So you can see the cholecystitis, although the incidence is very rare. Risk of choledocholitis, the stone moving into the bile duct causing jaundice, is uncommon. And then gallstone pancreatitis is one of the things which we do see now and then. We had 2 patients who were in third trimester of pregnancy in the last 2 years who had gallstone pancreatitis requiring intervention. And I've done ERCPs for 25 years. There are hardly a handful of cases where we need to do it. So it's fortunately, these are uncommon, but can safely be dealt with. Why does pregnant women develop gallstones? There is a supersaturation of bile with cholesterol. There is a gallbladder stasis with sludge formation, which can dissolve after the pregnancy. Sometimes that leads to stone formation. This will become a risk factor for the further pregnancies. And usually they are asymptomatic. Sometimes they can get biliary colic and right upper quadrant pain with nausea, vomiting, jaundice in patients who got infection, otherwise slipwood stone. So how do we investigate? We need to go for the ultrasound scan. As you can see the gallbladder. This is normal gallbladder, and you can see a stone sitting there with a post-echoic shadow. And if they come with the jaundice, what we do is we do the MRCP. MRCP clearly shows us where are all the stones and whether there is any missed stone in the neck of the gallbladder or in the lower CBD. That can be, further treatment can be planned. Sometimes if they are claustrophobic, we cannot do MRCP, we can do a EUS, endoscopic ultrasound. This is a transgastric ultrasound which shows a stone in the common bile duct in this particular patient. So, of course, when the patient comes to you, you should consider other differential diagnosis, and also don't forget to do the amylase test for these patients, as we have to recognize pancreatitis in very early stage. How do we manage? Most of the time we'll need expectant manage, reassure them and advise low-fat diet, and then antibiotics if it is a first attack of cholecystitis, and ERCP in case of choledocholitis, surgery if it is recurrent or severe, and then this can be safely done in the second trimester. So coming to the couple of points about the ERCP, safe with shielding and no fluoroscopy if possible. We don't take pictures to avoid excessive radiation. We reduce the exposed area. One important thing is to keep the lead guard on both sides of the patient, not only on the abdomen, to prevent radiation. And sometimes we will avoid fluoroscopy completely by combining USG-assisted bile aspiration, confirmation, and only stenting, and not to remove the stones during the pregnancy, and we can go for the elective treatment later. Surgical management, laparoscopic cholecystectomy, safe during second trimester, avoids complications in late pregnancy, and also we can do it in early third trimester. A lot of people may ask if they have stones after the first pregnancy, should they undergo prophylactic cholecystectomy during the second pregnancy. There are a large series of cases with no role of prophylactic surgery in asymptomatic patients. However, exceptions are if they are on restrictive diet and if they are obese and they have a diabetes or pre-diabetic state, you may consider counseling these patients for prophylactic surgery before their next pregnancy. Obstetric considerations, fetal monitoring is important. Risk of preterm labor and severe infections and in surgery-related issues can happen. That's why we postpone. We have to involve multidisciplinary team to take these things forward and then assess them properly. Pancreatitis is a very subject I cannot cover in short term, so we'll focus on some bullet points what you need to remember. So incidence is 1 in 1,000 to 3 in 10,000 pregnancies. Fortunately, it is less common. It is most common in third trimester, and also we do see cases in the early postpartum. I had 3 patients in the last 4 years who had postpartum, and we had a shared patient who successfully delivered second time without any problem, but now she came with a pancreatitis last week, which was mild. But there is another large group of patients in this part of the world who have chronic pancreatitis starting from their 20s. They may come with acute attacks. Fortunately, these attacks are very mild.